Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow, and I have a question for you. Where are you on the Bridge to Health today? Are you on the side of the bridge where you are unhealthy? Are you on the other side of the bridge and have crossed it and are totally healthy? Are you stuck in the middle of the bridge? That's the main question that we want to find out when a new patient walks through any of our offices. And our job is to assess where you are in crossing that bridge, what obstacles there are preventing you from crossing that bridge, and then with our team of specialists, all of us putting our heads together, working together as a team to get you across that bridge to give you the best state of health possible. As you know, each week we have a special guest from a different discipline. This week, I'm proud to have as our guest Dr. Pradeep Albert. Hi, Dr. Albert.
Thank you for having me on the show.
It's a pleasure. Let me tell you a little bit about Dr. Albert. Dr. Albert is a graduate of the State University of New York at Albany. He obtained his bachelor's degree of science, graduated magna cum laude before attending SUNY at Syracuse Health Science Center, earning his Doctor of Medicine degree in 1997. Dr. Albert completed his internship in internal medicine at Baylor College of Medicine in Houston, Texas, and his residency in radiology at St. Vincent's Hospital in New York City. He completed a fellowship in musculoskeletal radiology, which we're going to be talking about, at the University of California at San Diego in 2003. In 2002, Dr. Albert was the recipient of the RSNA National Research Award. Dr. Albert also lectures national and internationally on musculoskeletal imaging and is clinical professor of radiology. So a radiologist isn't just a radiologist. There are many different specialties within radiology. And as I said, Dr. Albert is a specialist in musculoskeletal radiology. Dr. Albert, can you tell us a little bit about what that means and what that entails?
Okay, sure. Thank you for having me again.
You're welcome.
Musculoskeletal radiology is the study of the joints. So when you go, people think of the radiologist as somebody that go in there and to get a test done. So let's say you have a chest x-ray done, or you have a sonogram done, or a mammogram done if you're a woman. The person that reads or interprets your study is a radiologist. So when you think about a radiologist, we are the physicians where, again, people get confused. We're MDs who are trained in in interpreting images. But specifically, musculoskeletal imaging is the science of where we evaluate joints, whether it's the shoulder, the knee, the wrist. So we spend extra time after our residencies just evaluating, whether it's from sports injuries, whether it's from systemic arthritis, whether it's from soft tissue injury, tumors, masses, anything related to the joint or the skeletal system, the musculoskeletal system, is what we study.
Right. So when we as really primary care portals of entry providers, when we have a patient come in with, let's say, pain in their knee, we do a clinical exam, orthopedic neurological testing, and then as practitioners, we really want to know what's going on inside that joint. We want to know before we institute any treatment plan if there's any type of tumor in the joint, if there's any type of fracture, if there's any type of torn structures, and that is what I understand your expertise is. You'll look at an image of that joint and be able to guide us as clinicians on what's there and the best approach to take, correct?
Yeah, that's exactly right. When you specialize, especially in medicine now, everybody's becoming super specialists. And in the world of radiology, it's no different. So in my practice, we basically we have subspecialties. So there are doctors that they're called neuroradiologists, as you know, Dr. Gray,
right?
Who look at nothing but MRIs of the brain. I mean, not that we can't do other things as well. Obviously, we're trained to do everything, but we specialize in areas. So getting back to musculoskeletal imaging, MRI of the knee, like, if there's a meniscal tear, if there's a subtle little meniscal tear that perhaps a non-subspecialty radiologist wouldn't pick up, because we look at so many knee MRIs, that's what we would pick up.
And I can't tell you how valuable that is to clinicians because some other facilities have just general radiologists who are not specialized and don't go through the extra training for those different specialties, reading films, and I mean, they're really not as qualified as somebody who has special training in that area.
Yeah, no, I agree. What's interesting is that as a radiologist, what happens is that people think about, when they get a test, they think about it as a place. They don't think about it as a person.
Right.
So, I'm the doctor that's behind the door where people will come and get, they'll go for a test, and they don't really always interact or meet with me. And they can. The interesting thing is if they actually stop and say, listen, I want to talk to Dr. Albert, I just, had a knee MRI,
right.
I'll be happy to talk to him. And in fact, I actually get pleasure from talking to patients, obviously, interacting with people like you.
Right.
That's very, very important.
Right. And what's really cool that I found working with your facilities, medical arts radiology, is that your radiologists, whether they're neuroradiologists, musculoskeletal radiologists, they're always so willing to get on the phone with us. And I actually go many times in person to meet with you and your radiologist to sit down with you and look at studies together because with me giving you more clinical information about what's going on with the patient, we can both look at the study and really zone in on what the problems are we're looking for. And it's invaluable to a clinician such as myself to have that dialogue. This is what I was talking about when we first started, is it's crucial that your healthcare providers that are taking care of you are communicating with one another, acting as a team. Would you say, Dr. Albert, that most practitioners who order diagnostic studies such as CAT scans, X-rays, MRIs, that most of them just look at the reports and never look at the films themselves? Most practitioners?
Absolutely, yeah. What's happening is, unfortunately, and let me just reiterate what you just said, the teamwork approach, you were talking about the bridge to good health. The bridge is, it's a whole teamwork concept. And if you don't, what you do, which is to take time out of your day to care about your patients enough to discuss their findings.
And come to your office.
And to come to the office.
Right.
And, I mean, that takes time, dedication. and what's happening, unfortunately, in healthcare today is that doctors are being squeezed for time.
Right.
Reimbursements are lower, so doctors have to see more patients per square time, I guess.
Right.
If I can say that.
Right.
So, yeah, unfortunately, what's happening is that many physicians, get the report, and they don't always take the time, extra time, to kind of go over the results that you do.
Right.
But what we do, at least because remember, it's a two-way street. Because when somebody says, how come you didn't call me? You can always call me. So we in my practice in medical arts, what we do is, and what I do personally, is I always like to pick up the phone to talk to the physician.
Right.
Because how many times have we had an MRI of the spine, et cetera, where there could be a small disc herniation in one area, and the patient's not symptomatic there.
Right.
And having that real dialogue and going over the pictures, you examine the patient,
right.
All the things that you do.
For instance, you'll call me and you'll say, well, Doc, what do you got on this patient? I'll say, well, this patient has a decreased L5 reflex, patella reflex. They have decreased skin sensation of the nerve roots that govern the L5 skin sensation area called the dermatome. And they have a positive EMG test, which is an electrodiagnostic test, which shows how the nerves are functioning, that shows the L5 nerve roots affected. I then sit down and I give you this information, and it kind of like helps you zone in on what the real symptoms are of the patient and how better to look for what's going on. Is that true?
Yeah, absolutely. Clinical history, and the advantage that we have is with these modern machines that we have, we can look at every little thing. The disadvantage is that the patients are separated from us.
Right.
They're your patients in terms of you're examining them.
Right.
You're sending them to our facilities for imaging.
Exactly.
So talking to you and getting that clinical history is a huge, interactive process is huge.
And in our facilities, our 4 locations, all of our doctors, who we call the quarterbacks, that then determine what tests or what specialists the patients need to see, they all have extensive postgraduate training in spinal MRI interpretation, so that we're able to actually look at the films, see something, and then discuss it with somebody like Dr. Albert, so we can confer and really find out what's going on.
Absolutely. I think it's, again, that entire teamwork approach. And also, we also take the extra time whenever a patient fills out a questionnaire. I've actually called patients. I said, hey, listen, I looked at your MRI, and, did you have any surgery? Why is there something here? Why is there metallic? Did you fall on, So there's, talking to the patient, talking to you, talking to referring doctors is such a big part of what we do.
Definitely.
And I think, we talk about medicine, right? We talk about there's a science of medicine, right? Which is just looking at the actual science and looking at the pictures. But the art of medicine is kind of like,
right.
this sort of team approach, kind of looking at the whole gestalt, the whole picture.
Yes. It's funny, not to get off the topic, but as far as patients giving us information, sometimes they don't give us, as clinicians, everything we need to know, or forget things or intentionally withhold things. Right. So imaging is very important. I'll give you an example. We had a patient come in once after a car accident, and I did a complete history on the patient, any prior trauma, any prior car accidents. No. I do plain film x-rays of him in my office, and I see a bullet wedged right up against his abdominal aorta. True story.
Wow.
And if I did not take that x-ray, which unfortunately a lot of practitioners out there don't before they manipulate, but if I had not taken that x-ray and laid that patient on my table and adjusted him, I might have pushed that bullet through his aorta and killed him.
Right.
So imaging is very important, and again, we don't always have all the information we need on initial intake, and the imaging sometimes will give us more information, life-saving information.
Absolutely,
Right.
it's really revolutionized modern healthcare.
Right. I mean, when we have a patient come in and we suspect they have a herniated disc, let's say at L5S1, the last thing we want to do is give them a hard manipulation in that area if the disc is fragmented, if it's extruded, because we could do more damage. So we need that information clinically before we can even go on and try to help that patient.
Yeah, absolutely. It's also, what else is great for our baseline? When
Yes.
the patient gets started,
Yeah.
So if the patient gets started this way, are they getting better? Are they getting worse? So for so many different things in medicine, sometimes we don't have a baseline, and we just kind of go by what the patient tells us, which is important, obviously. How they feel is very important, but to have some kind of documentation which basically says, hey, you started here, look, you're getting better,
Right. Dr. Albert, I would venture to guess that most people think that radiologists have no patient interaction and they sit behind a desk all day and dictate reports. You actually perform procedures in your office, right?
Oh, absolutely.
And what types of procedures do you perform?
I would say about half my day is spent performing procedures. Whether it's pain injections, for example, if you have chronic pain and the person is refractory to, conventional treatment or pain medications, people would send me their patients in order to be able to
What type
get
of injections?
pain relief. Basically, any kind of joint. So again, I'm a musculoskeletal radiologist. So anything that has a joint, any kind of soft tissue inflammation, and many procedures of the spine. Basically, we take using image guidance. And you got to remember, right? As a radiologist, we're the first one to start imaging patients. So my field of expertise is really musculoskeletal ultrasound. So using real time, you got to remember, right? Like if you take an X-ray, it's a point in time.
Right.
When you're using ultrasound, I can really see where my needle's going. I can look at that joint space. So let's say you get a shot in your doctor's office. They're kind of using anatomy, and they're just kind of figuring out where it is, and they're kind of guesstimating where to put the needle. Well, using my imaging techniques, I know exactly the anatomy of where I'm supposed to go, and I'm getting that needle to that particular point, and then I could put the medicine or the pain relief or whatever that I'm putting into that particular area. And that really, really makes a huge difference. And since I'm a doctor's doctor, and as a radiologist, we get referrals from other doctors. People don't just come off the streets to see us directly. So we get very, very tough patients that have been to other places that haven't had any relief.
Can patients come off the street directly to see you for pain management, or they need a referral?
Most of the time, they need a referral. We will see patients, we talked about PRP before, but there are some procedures that I do which are where the patient can see me directly, which are some of the, for example, primarily for platelet-rich plasma, which is the science of which where you take the patient's blood, spin it down, and you have the growth factors from that particular patient, kind of injecting into the area of injury. And again, we talk about image guidance, and there's nothing better than actually looking at a small little region of inflammation at the level of the elbow, putting the needle right where it is, and actually seeing it real time and putting the medicine right where that is.
That's pretty awesome, man. Now, another question I have, how many facilities does Medical Arts have, and where are you located?
Well, we have 7 facilities as of now, and we're both located both in the North Shore and South Shore, pretty much all over Long Island. Far east as Setauket, Patchogue. We have offices in Comac, Huntington, Plainview, Bayshore, West Islip. Did I forget any? You know what? We've been very lucky in this contracting healthcare environment. We're expanding.
That's awesome. Well, because you do great work. That's why you're expanding.
Thank you.
Do all your facilities have this injection treatment therapy, or just certain ones at certain facilities?
Like as we talked about, all of our facilities are equipped. We take all insurances. We can pretty much do everything. But as we talked about, remember, you're not going to a place, you're going to a person. So myself and Dr. John Parnell, who are the 2 musculoskeletal radiologists in our practice, wherever we are, that's where these pain injections can take place. So,
do most other radiology facilities have actual pain management and actual treatment of patients, or are they basically just imaging?
Most places, I would say, from my experience, because we do get actually patients from other places that don't do these injections. So in my experience, at least here on Long Island, most places do not do that. We're one of the few people.
You're pretty unique.
Yeah, in that way, yes.
Nice. So when a patient gets an injection, how long does that pain relief last usually?
That's a very good question. It's probably the #1 question I get asked all the time. Hey, doc, how long is this going to last? Is this cure me? Unfortunately, depending on the type of injection, for the steroid injections, they can last for anywhere between 3 to 6 months. So it's pretty good time, sometimes, let's say that there's a ganglion cyst or something kind of like biomechanical that's blocking, joint motion, etc. And if we put a needle in it and aspirate it and get rid of it, then that could be curative. So it really depends on the procedure. If it's a pain injection, it could last, for a steroid, etc., it could last 3 to 6 months. If it's something like curative, where we're trying to take out an anatomical structure like a bad appearing cyst or a parameniscal cyst or something, that's kind of interfering with normal joint function, then we can actually cure the patient's symptoms there. So it really varies.
Wow, that's pretty cool. Dr. Albert, could you just let the audience know a little bit about exactly what an MRI is and what the difference between that and a CAT scan, and what it actually does and how it works? Could you let the audience give an idea what that is?
Sure, absolutely. MRIs are so all these different modalities, right? Basically take pictures of the body. So you have different ways of doing it. Initially, X-rays were the first things that came out. So a CAT scan, let's start with X-rays and CAT scans, because historically that was the first type of imaging that was performed. So a CAT scan is basically an X-ray tube that spins very, very fast around your body. So there's actually a motor, and it spins around your body really fast, and it takes a tomogram or a picture, like an X-ray slice, through that particular part of your body. The computer reconstructs it, puts it together, and makes like an axial or picture of that particular part of your body.
The axial is like you cut the person in half,
you cut the person, like,
and you look
right
straight
through, exactly. It's like a salami, you just slice it through.
The next view would be cut a little further down.
That's correct, yeah.
And you're actually looking at these different slices and seeing what's going on inside the body, right?
That's correct.
Right.
And that is one of the most incredible, discoveries in medicine, because it's factually changed. Before, if you had appendicitis or something like that, your doctor would have to, rely on a gut feeling. Excuse the pun.
Manual palpation.
Exactly, absolutely.
A
physical
right?
exam is such a big deal, and now, now we can be more. And people used to have surgeries. I don't know if you remember back in the day, we used to have stuff like exploratory laparotomy.
Yeah,
which
exploratory surgery. Yeah,
right,
let's see what's going on. We can't see in there. We got to
just
look.
Don't understand. So let's take a look in there. So exploratory laparotomy was a very common procedure that was done before, and it's unheard of now. Unless there's the patient has pain and we just can't figure out what it is. It's almost unheard of today.
Right.
So really, so if you think about, from that point of view, this imaging has changed medicine significantly. So that's how X-rays, again, that uses ionizing, that uses a small amount of radiation.
Right.
And speaking about radiation, I'll tell you something interesting about medical arts radiology. We have invested significantly in low-dose CAT scans. So our CAT scans have much lower dose than some of the other places you can go to. And it makes a big difference because, you know, there's a principle in radiology called ALARA, as low as reasonably acceptable. And you really don't want to, sometimes you don't need an imaging study. You know, that's the other thing is that, you know, as a radiologist, you want to be able to discuss, get on the phone with somebody and say, hey, you know what, maybe this is not the best test for the patient. You know,
I do that with you guys all the time.
I know you do.
I have something going on. What test do you think is best? Because as a clinician, I don't know. That's your expertise.
That's right. And also, and I appreciate that because, you know, that going back and forth, remember, like, you know, it's your patient, but now for that short interval time, it's my patient too, so I want to make sure that they're in good hands.
Right.
So we don't want to, you know, put any, you know, bad risk on these patients. So at Medical Arts, we use low-dose CAT scans, which we started doing before. There's a lot of recent literature that came out. We did it, you know, many years ago, and we've been doing it, and we kind of keep track. And, you know, there's certain people that we don't want to do studies on.
Let me ask you a question about statistics, if you have them off the top of your head. So if an X-ray is, let's say, 10 value in radiation, let's say 10 rad or whatever, as an example. A CAT scan, which is not low dose, would be how many more times that? How many X-rays would that be equivalent?
Yeah,
not the ones you have.
Not the ones we have.
Not the ones you have.
Yeah, right.
But the ones that are out there that are not as highly sophisticated as yours.
Right, okay. So just to go back from a technical point of view, again, there's different types of X-rays. There's X-rays and there's digital X-rays. We have digital X-rays which actually, again, reduce the amount of radiation. So the ones that are run with the old film, you know, that you have to run through the processor, they actually used to have a lot of more radiation. And those things are slowly being phased out, as you know. So I would say the ratio is almost 1 to 1,000 now. You know?
1 to 1,000 for an old CAT scan?
That's correct, yes.
And what is it with the new ones you have?
We have about 40 to 60% reduction in radiation.
Wow, that's
significant. Yeah, absolutely.
Wow, that's a big amount.
Yeah. And you know what? The other thing is that you got to remember, right? People are afraid of all these different things in terms of radiation, and rightfully so for certain people. But after a certain age, you know, it's all about the relative risk of developing cancer. And we've had a lot of data, you know, unfortunately from many of this was done after World War II with the
Hiroshima.
Hiroshima, exactly,
yeah.
exactly, Nagasaki, Hiroshima. We have a lot of studies which show that your lifelong risk of cancer after you basically turn 40, and you know, unfortunately, I'm above that line now, but the amount of radiation that you get doesn't really affect your lifelong, you know, risk of anything.
I read that same study. I was blown away. I couldn't believe what the exposure those people got from that nuclear explosion.
That's right.
If they were over 40 or 50,
it didn't
really affect their cancer rates.
That's correct, exactly right.
Because radiation really affects developing younger cells, correct?
That's correct.
Right.
So, especially for, you know, we use the American College of Radiology, which is our governing body, has something called Image Wisely, especially for children.
Right.
So, for children, now, the great things about MRI is there's no radiation for MRI.
That's going to be your next question. I want you to let the audience know that.
Right, exactly. MRI is great because there's no radiation. Right. Ultrasounds, no radiation. That's why the procedures that I do, a lot of them are under ultrasound guidance, because I can see exactly where I'm going, and there's no radiation to the patient.
Are there any patient categories where an MRI would be contraindicated?
Oh yeah, absolutely. Unfortunately, MRIs, as you know, many people are aware, if you have certain types of metal, now that doesn't mean all types of metal, but certain types of metal, like especially if you have, you know, shrapnel from like, you know, war injuries, or foreign body from like, you know, industrial accidents, those types of things preclude you from getting an MRI. But if you have a hip replacement, you're fine to get it because it has to be ferromagnetic. The MRI machine basically attracts, you know, magnetic material.
Right. What about spinal fusion hardware?
That's totally fine.
Yeah.
It's absolutely fine.
I have patients come to me all the time. Well, I can't have an MRI. I had a spinal fusion.
Yeah.
And they're not aware that they can still, because it's not magnetic, that metal, right?
That's great. It's usually titanium, so it's non-ferromagnetic.
Right, right.
It's a very expensive metal that they put in the body.
How about pregnant women?
Now, that's a very good question. In the in many places, especially for fetal abnormalities, in the third trimester, they actually do MRIs to analyze the fetus and the baby.
Right.
It is kind of contraindicated in earlier pregnancy. So it's not really advised earlier in pregnancy.
Now, correct me if I'm wrong. I've read studies, not studies, but actually opinion papers on this. And from what I've learned, and maybe I'm wrong, maybe you know something I don't know, is there really never has been any study which has shown damage to an embryo due to MRI, and they're kind of just don't want to do it just in case there might be. Is that true?
That's exactly right. That's exactly right.
So they're just playing it safe, but there's never been any proof or any incident where a newborn embryo has been injured from an MRI screen.
That's correct. And many
Right.
times women are pregnant, they don't know it yet, and they have MRIs done
Right.
on them of their
Right.
knees, et cetera. So that is true. But we kind of try to, tell people to, at least the first trimester,
Right.
to avoid it.
Just to be on the safe
Just
side.
to be on the safe side.
Right. What if a patient can't afford an MRI or a test? What do they do?
Well, we take all insurances at my practice, but, we have a program that we call the Art of Giving. We, Medical Arts, a practice that I'm a part of, we've been a part of the Long Island community for over 75 years, I believe. So for a long time, long before I came. And so before, some other places give you, possibly some break
Right.
here or there every other weekend or some obscure time, but we do it every day. So believe it or
Wow.
not, there are people that come to our office because we're part of the community. We are the community.
So you'll help them out.
Absolutely, and there's a criteria that we use, and but there are many times, and we do it like again. It's not just one day, one time.
Dr. Albert, that's a beautiful thing, man. You're going to heaven.
Thank you.
Thank you very much for being our guest on this show, and we're going to have you back on the next show to talk about some other real interesting topics. For those of you in the audience who are watching us on Madhouse TV, stand by. We'll be right back. For those of you watching us on Cablevision, we'll see you next time. Have a great day.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow, and I have a question for you in the audience. So, in World War II, Vietnam War, many wars, when there was a battle raging on the battlefields, the first thing that the Air Force was instructed to do was to take out the radar. And the reason why they were instructed to take out the radar is because if the enemy had no idea where the other forces were coming from, and the enemy had no way of communicating with their own forces, there would be chaos on the battlefield because there'd be no coordination of any of the troops. No one would know where to go, no one would know what to do. Does your doctor who takes care of you know what all your other doctors are doing? Is anybody coordinating your care? Or is everybody kind of like doing their own thing? In our offices, we have a quarterback that coordinates all of your care with all of our specialists who are part of our team so that our radar is never knocked out and that everyone knows exactly what the other person's doing and working together for you, the patient. Today, I have Dr. Pradeep Albert back with us again, a musculoskeletal radiologist. Welcome back.
Thank you for having me.
Thanks for being here. So, why did you choose this specialty?
Musculoskeletal radiology. You know, I've always, even though I'm not very athletic, I always wanted to be athletic. Mm-hmm. And I really enjoyed, watching sports. And frankly, I thought it'd be interesting to look at the anatomy and the physiology of sports injuries. Mm-hmm. So that's kind of what drew me into the field, frankly. And I just find it fascinating that, as a radiologist, we look at images, but as a musculoskeletal radiologist, along with just looking at static images, especially with ultrasound, which I do quite a bit of, I love looking at dynamic moving images. You talked about radar in the introduction, which is a perfect segue into talking about musculoskeletal ultrasound. When you take a look at a patient, with some of the pictures that we have, you can take a look at a point in time. I can, when I'm doing a procedure, I can take my probe and look at the patient, and as the patient moves their rotator cuff, I can actually watch it move underneath the acromioclavicular joint. Or I can watch, a hip adductor muscle, or flexor muscle, or a hamstring muscle kind of do its function. So it's very, very interesting, and I frankly just kind of love what I do.
Wow, that's pretty cool. So you're actually, before you treat that area, you're looking at how the joint functions, you're looking at how it doesn't function,
That's correct.
Making an assessment of what's wrong, and giving your treatment specifically kind of like a guided missile.
Right,
Right
exactly.
at the point where it needs to be.
Absolutely.
Wow.
So, I mean, it's very important because, a picture is worth 1,000 words, but, we're basically looking at kind of a movie of the human body.
Right.
the functional portion of how your joints are moving, how your knees are moving. Now, having said that, obviously to start with an imaging study such as an MRI is very important, so you can look at the anatomy very clearly, because not every imaging study, like, for example, one of the most commonly asked questions that I get is what's the best test, right? And
Right.
we've talked about that before.
Right, right.
So somebody will say, well, I want an MRI of this because they think it's the best test. Or they want, some other test or a bone scan because they think that's the best test, or et cetera. But for each diagnosis and for that particular part of the body, there's a different imaging test.
Right.
For example, MRIs are not optimal for looking at bony pathology.
Right.
You can look at, you obviously, an obvious fracture you can see, but if there's subtle, changes to the bone marrow or the cortex of the bone, you're not going to be able to see it well. And whereas a CAT scan and X-ray would be much better for that.
Right.
So there's no really one study that's better than other studies.
Right.
It's kind of looking at the whole, picture together.
Right. So as we talked about on the last show, what an MRI really is a computer-generated image of basically different slices of your body cut. So what we call a sagittal image, if you take the body and cut it straight down the middle and then look in from the side, that's called the sagittal image, and we can see exactly all the structures in the spine and the organs from the side. If you cut the body this way and look straight down, that's called an axial image. We're looking down. So we're basically, with this computer technology, able to chop the body up into many parts as we want and look in there and see what's going on. But there's something even cooler now that's out there, and it's called 3D imaging. Can you tell us a little bit about the 3D imaging?
Sure, absolutely. Now, the advent of the computerized exam, which, you have to remember, well, the fascinating thing about radiology, and the thing, I love technology. Obviously I love talking to people and, talking to you, but, in medicine, very few fields are as technology dependent as radiology is. So as you described, what happens is that when the first picture is obtained, an axial image can be obtained, and now we can get an entire data set of your whether it's your heart, we can have like a 3D data set of your entire heart. We can, instead of having a conventional angiogram like you would have to have looking for coronary artery disease, we can put a small IV in your arm, have the dye go through your body and catch it and do an angiogram of the heart while it's beating with the technology that we have. We have a 3D model of the heart.
Wow.
So there's...
Can you rotate that any way you want and take a look
yeah,
at it?
Absolutely.
So you can actually take someone's heart on the monitor and turn it, look at it over here, look at it over here.
Absolutely.
Wow, that's pretty incredible. It's like actually being right inside there and moving around.
That's right. One of my partners, Dr. Barry Morgenstern, he's an expert on cardiovascular imaging, and that's what he does all day long. And it's, I watch these, 3D pictures go through. And in my field, in musculoskeletal imaging, if you're looking for a rotator cuff tear of the shoulder, looking at the pictures or looking at the bony anatomy to see, well, there's a big spur here. There's no way this joint's ever going to move up this way. That's fascinating.
Wow. So let me ask you a question. So traditional testing to see if somebody has a blocked coronary artery after they have failed maybe an echo or a stress test is they do an angiogram where they go up through the the groin, and they with a scope they go in and they actually look inside the artery. Correct?
Well, no, they put a small catheter in and they just inject dye. Yeah.
Yeah. So my question is, that test that you just spoke about, a cardiac cath,
That's right.
Is that just as good or a replacement for an angiogram, or is one indicated with certain conditions and another indicated with other conditions?
That's a very good question. The coronary CTA that we do is very, very good in that it replaces the need for many of the diagnostic procedures. Before, they would have to do that. It's an invasive procedure. You have to put something in your aorta going all the way up and kind of injecting dye into your coronary arteries. It's not the, it's not the safest thing in the world.
It's invasive. You're cutting the skin and you're going into a blood vessel.
Absolutely. That's not optimal. So now we're getting the same information without having to do that.
So we don't need to do that anymore, yes?
Yes. Well, I mean, let me, the cardiologists are going to get upset with me for saying you don't have to do that anymore.
Okay.
There's still a need for that. Like, for example, sometimes, let's say you wanted to go in there and look at it and then fix it at the same time.
Oh, I see.
That's the time to do that.
Okay.
But let's say that you just want to get yourself checked out,
Right.
You know, you want to know how you're doing, and you want to make sure you really don't have bad coronary artery disease.
Right.
There are some people that are on all sorts of medications because there's the assumption that they have coronary artery disease. But now you can see whether you have it or not.
Right.
And if you don't have it, then you may not have to be on as many medications as you had to be on before.
Right.
So it really changes everything.
So would it be fair to say that if you got a person, he walks into the OR, he's got left arm pain, he's got chest pressure, he's got chest pain, he's got all the clinical signs, and blood tests would show he's got heart enzymes, that he's having a heart attack, that's a catheterization procedure as opposed to a cardiac cath?
That's correct.
Because if you're in there, you're going to fix it right then and save his life.
Right.
Whereas if somebody isn't really that symptomatic and they just want to kind of check out to see the integrity of their cardiac vessels,
Right.
that's where you go for like a cardiac CAT scan, right?
Right. Now, what's interesting, what's happening nowadays, and this is new, in certain, especially in an acute care setting, they're doing these CAT scans now, the CAT scans we're talking about, to rule out a coronary artery disease and a pulmonary embolus or a blood clot in your lungs all at the same time. So you can actually do it in certain hospitals in the emergency room when somebody has really bad chest pain. Instead of, because they would have to guess, they would have to wait for the blood work to come back. They would
Right.
have to, look at the EKG and wait for all
Right,
those things
right.
to come back. Now we can rule out a coronary artery disease and a blood clot in your lungs, which are the two biggest.
And so it saves you time
Exactly.
without having to wait for all these lab works to come back.
That's correct.
Cool, cool. So there's other 3D technologies to diagnose things, such as what we've spoken about the colonoscopy,
That's
3D
right.
colon. Can you tell us a little bit about that?
Sure. So just like we talked about with the shoulder and the heart, and this is part, the virtual colonoscopy is basically you kind of just get a CAT scan. You're just kind of laying there, and we reconstruct the images. Now, obviously, there's a catheter that kind of goes into your rectum to just fill you up with gas. So
There's a what?
It's a little catheter.
Okay.
It
Right.
goes into your rectum.
open
and
the
then
bowel up a
Open up
little
the
bit.
bowel up. We put some air in there, and it just kind of opens up and distends the bowel. And then you get a CAT scan. And, as opposed to having an invasive colonoscopy, which, certainly has.
And as we spoke about earlier before we came on set, you said this is kind of like you could actually walk right through the colon and look at whatever part inside you want as if you were inside there, right?
That's right, absolutely. You can kind of, we call it fly-through. I'm not sure if it's the most pleasant experience in the world to kind of fly through somebody's colon, but certainly we can, look and kind of walk through the colon, and if they're polyps, we can, figure out where they are, we tag them, and then we can,
Do they need any dye or injections for that before they have it done? Is there any contrast?
No. What happens is that they take a prep, because you really want to, clean out your.
Like they would with a regular colonoscopy?
That's correct,
Right.
exactly. You want to give something like that. They also take a substance that comes along with that, which marks the stool, so the computer can subtract the stool out.
Wow.
Yeah, it's amazing what it can do.
And that's something that would be residual left, God bless. That would be something that would be residual after cleaning somebody out with whatever they take, residually left in there that would be there with a traditional colonoscopy that they can't get rid of, correct?
Yeah, I mean, well, the prep is very similar. So, there's going to be a little bit of stool. Usually when we do the patient, by the time that we get the patient, there will be nothing left in there. So the Tagatol just like marks the stool so that, it can
Okay.
be taken apart.
So again, similar question to the cardiac CT as opposed to an angiogram. Is this as good as a regular colonoscopy with anesthesia and a scope? Is it a replacement for it, or is one indicated at certain times and the other indicated at other times?
That's a great question. I think the best answer to that question is the last option that you gave, which is, in medicine, whatever it is, if somebody tells you that this is the test and there's no other test, that's better than this test, they're just saying the wrong thing. There's indications for both. Obviously, if somebody's actively bleeding or if they have a real, lesion or something else that they saw, during a colonoscopy, during a conventional colonoscopy, you can go in there and cauterize a polyp or take a biopsy.
Right.
Okay. But for certain subset of patients, that's not necessary.
Right.
For patients that are, there are people that cannot get colonoscopies.
Right.
The technical limitations of getting the scope around certain parts of the colon are not that easy.
Well, as you and I as professionals know, and I hope the audience knows, they may not, with any procedure, there's a risk from
Right.
having the procedure. And when you have a colonoscopy, I mean, you have an anesthesia risk, You have a slight risk, not great, of perforating the bowel.
That's right.
Many different risk factors which aren't present with this cardiac colonoscopy, I mean with this virtual colonoscopy. They're all eliminated, correct?
That's correct, absolutely.
So my question to you is, I just had, and bad me, hit me on the head, I just had my first colonoscopy done at 58 years old. I should have had one done a long time ago. Thank God everything came out normal, but it was not a pleasant test.
Yeah.
So for somebody like me who's never had any symptoms, no bleeding, just a exam to see what the state of my colon is, would this be a substitute for a regular colonoscopy? Would it give you just as much information?
There are some people that use this as a screening exam. Absolutely, it can give you very, very specific information about your colon. And, depending on the different societies, people...
There's different opinions.
Different opinions,
Yeah.
As a radiologist from the societies that we belong to, yeah, absolutely, it can be,
Do insurances cover that procedure?
Absolutely, yeah.
Wow.
It's very, the number one indication that we get right now is our friends, the gastroenterologists, when they do the colonoscopy, sometimes they can't get around certain parts of the bowel. So those patients they've had a conventional colonoscopy in the morning, and they can't see everything, and they send them over to our office, and then they have a virtual colonoscopy.
So if the bowel is contorted or it's twisted, and
That's
they're trying to stick that scope up there, and they can't get around the curve or something like that, this would be helpful in the areas they can't visualize with a regular colonoscopy.
Right, absolutely. We work with them. So it used to be when this first came out, there was a lot of controversy about it. Oh, is this going to replace a colonoscopy?
Right.
But it's more of it, like, you talk about the bridge to health, the teamwork approach. We work with the gastroenterologists
Right.
so that, we're not certainly here to take it, because what
Right.
they do is obviously very important. So it's just more information to try to make the whole
Right, and
process
if you've got
smart.
patients that are high risk for anesthesia, they're elderly.
That's right.
They have a past surgical history of what it might be contraindicated. They may have uncontrolled hypertension, uncontrolled diabetes. This is definitely
The way to go,
beneficial
yeah,
for them,
absolutely,
right?
yeah.
Okay, great. How difficult is it to get an appointment to see you? Because I know the answer to that question, but I want you to give the answer. Because I've had patients that have used other facilities, and they come in, oh, doc, I can't get in there for 3 weeks. And I'm like, 3 weeks? Are you kidding me? I need this information now. How difficult is it in your facilities to get in?
Well, it's the answer to that question. It's a mixed blessing. Sometimes it's very, very good to be busy, right? As you know, I'm sure I know you're very busy.
I tell my patients all the time when they complain about waiting for a little while because we're packed, I tell them, if you don't want to wait, that's fine. There's an office right down the block where there's nobody in there, and you'll get in right away.
Right.
But think about why there's people here.
Right, exactly. That's why people wait to see you.
Right.
Having said that, we have expanded our hours now, so that we are open till like 8 or 9 o'clock at night in all of our offices.
Wow.
Yeah, and
You open the weekends too?
Absolutely, we're open on Saturdays and Sundays.
Sundays too?
Yeah, absolutely.
Wow,
yeah,
that's
so we're
great.
open all the time. We've been very blessed to have a huge patient load. Knock on wood.
Knock on wood.
Yeah. So it's as you know, every time you call me and you want to get a patient in, I will see them.
Yeah, you're very accommodating. All your staff, all your facilities are very accommodating. So very often, not very often, but commonly, I'll have a patient come in with another MRI from another facility. I'll look at that MRI and I'll look at their report, and I'll see things on that MRI study when I look at it on my monitor that radiologist has not reported on their report. I then bring that study to you or to Dr. Gray or somebody in your facility, and you guys are always more than happy to sit down with me and interpret another study from another facility.
Absolutely.
Do you do that often?
Yeah, quite a bit. I mean, ideally, because of the quality of the machines that we have and our staff and the protocols that we have, we would like to have the patient scanned in our facility.
Of course.
But if that doesn't happen, we love what we do. Like Dr. Gray, I was just talking to him on the phone before I came here. We're talking about a patient that we were going over. And I think, as radiologists, as doctors, we'd like having the relationship with somebody like yourself.
Right.
Where, we talked about earlier today, where, we're talking about going over studies together. You
Right.
take time out of your busy day
Yep.
to come over, and you do that for your patient.
Yep.
So, again, the same way, I would be happy to take a look at somebody else's MRI,
Yeah.
take a look at it, and give them
And
my opinion.
you've actually generated new reports on those other outside films for us, which I think is awesome.
Yeah, we can, yes.
So, rumor has it that you have interpreted studies on some pretty famous people, sports figures, yes?
Yeah, we have,
Celebrities?
as a adjunct, I do a lot of, teaching and lecturing in musculoskeletal radiology. So I get to travel, luckily all over the country to do some of my lectures and things like that. So I work with some, pretty famous people. I want to be,
Yeah, I know you can't say who they are, but they'll send you over the computer, the studies, you'll give them your opinion.
I will, yes, I have, yes, and a lot of these people kind of want to keep everything,
Especially the sports figures too,
yes,
right?
exactly, yeah. I've looked
Because
at
the sports
several-
people
yes.
don't want the other team to know what's injured, right?
That's correct, yes, yes. There are people that are in imaging that, that I have worked with, and my colleagues have worked with, that, obviously patient confidentiality is very important, but
course.
we actually have people that actually, for some of our procedures, we've had people that travel from, all the way from Florida or other parts just to get some procedures done, so.
They come from Florida to your facilities?
Well, I think what's happening is that a lot of them are from Long Island originally, and then they move down there.
Right.
And then they save their medical care for a particular month, and then they come back up. I know myself and Dr. John Parnell, who's my, partner at Medical Arts, we certainly have our share of people. Sports imaging is one of our favorite things to do.
Right.
And procedures are, things that we love to do.
Have you imaged any professional athletes?
I have. Now, I've had to look at them with some of my colleagues. That's in my field of, doing these lectures that I do, around the country. And I've had people, say, hey, Pradeep, what do you think this is? And we've looked at it together. Or, they call me in the evenings and just kind of like, that's more of a screen sharing thing where
Right.
I look at these things with some of my colleagues from other parts of the country.
Right.
So that's very, absolutely.
Right. One of the things I like the audience to understand is that as a doctor of chiropractic, I have to explain to patients all the time who come to me on initial exam and said, oh, I've been to a chiropractor before, I've been to 2, I've been to 3. What I have to explain to them is that's okay, but chiropractic is not just a science, but it's also an art. And the art is our ability to feel with our hands, which is called palpation, the exact position or malposition of certain vertebra or other joint structures in the human body. And then with our hands, very skillfully and very precisely in a 3-dimensional plane, in a 3-dimensional XYZ axis, be able to put that structure back where it should be in 1 or 2% gradients at each visit. This is an art, and this is different when you go from practitioner to practitioner. The difference between a regular primary care doctor and a doctor of chiropractic is when you go see a primary care doctor, he uses his brain. He examines you, he uses his didactic knowledge that he learned in medical school. He then comes up with a diagnosis and then either refers you for testing or sends you somewhere or writes you a prescription on what he thinks will best help you. We have to do all that, except we don't write the prescription. We then have to put our hands on you, and then with our art and with our skill, be able to effect a correction that will make you healthier and help you get to the other side of that bridge, which is why I've heard many people who have said to me, oh, I've been to cocktail parties, I've been out in social gatherings, and one person says the chiropractic created miracles, the other says, well, they didn't help me. It's because it's an art. It's not something that everyone possesses the skill for. Likewise, with many people think that radiology is an exact science and that it is what it is and that every radiologist will say the exact same thing when they see films. And I'm sure from our conversations, the audience needs to know that this is an art also.
Absolutely.
It's a subjective interpretation based on your training, based on your skill, that is your opinion. And where another radiologist who looks at that film may not have the same opinion. Am I correct?
That's absolutely right. Any two people can look at the same picture and come to a different conclusion. And that's why I think it's very important. A good doctor is never afraid of a second opinion, in my opinion,
Right.
And so we look at images, every single day, like for example, in musculoskeletal imaging, one of my partners, Dr. John Parnell, and I would look at the pictures together, and I call him up and say, hey, John, what do you think this is? So we have a back and forth and say, he'll say, and he's a very bright guy, he'll say, you know what, I think this is a, you know, it's a partial tear.
Right.
And we'll take a look at it again. You know, we kind of have like
Right.
a dialogue.
It's another fresh set of eyes.
That's right.
Right.
And technology allows that. You know, every day I'm on the phone with, you know, we talk about Dr. Gray, you know, with Dr. Gray or Dr. Parnell, kind of going through all the things that, you know, through my day, and I'll say, hey, what do you guys think this is? And I value their input.
Right.
And
You're working as a team.
Yeah, work as a team. Just
Exactly.
like, you know, yeah.
Exactly. So, just recently, I brought my father-in-law over from Puerto Rico because he had a very serious fall, a spinal cord contusion, and for about 3 months, he couldn't move 3 of his 4 extremities. Finally, he got movement back in all but his right arm, and he had all kinds of tests done in Puerto Rico. He had an MRI of his shoulders, which their reports said were negative for any tears or anything like that. So I just brought him into your facility. He had his left shoulder done last week, and we saw a slap tear, big tear in his shoulder. So again, if you're out there and you have been to doctors and you have had MRIs done or other tests done which the reports said negative, nothing there, it might be prudent for you to come to Medical Arts Radiology or to us to have a fresh set of eyes, look at your complaints if you're still in pain, and maybe look at those MRIs again or the tests you've had done again, or maybe do new ones with better equipment so we can really give a second opinion or a better idea as to what's going on. Dr. Albert, I'd like to thank you once again for joining us, and I hope you come back again in the future.
Thank you very much. I had a great time.
It was very pleasurable. And for those of you in the audience, thank you very much for watching The Bridge to Health, and we'll see you soon. Have a great day.